Good evening everyone. Presenting my paper on ocular motility disturbances after a scleral buccal surgery, double trouble. I have nil financial disclosure. Following a scleral buccal surgery, nearly 50% of the patients develop transient strabismus which remains persistent in about 5 to 25% of the patients. The major etiology ranges from restrictive adhesions, muscle damage to sensory deviations. Because of these varied etiology, the treatment of these type of strabismus is also variable. Hence, through this study, we would like to describe clinical features, management protocols, and the outcomes of different management protocols in patients with strabismus post-scleral buccal. Totally 19 patients were included who had persistent diplopia and tropia after a scleral buccal surgery. Any foveal pathology were excluded from the study criteria. Thorough strabismus evaluation, including primary, secondary, and extraocular movements, were assessed. Type of the management and if surgery done, what was the surgical technique used, and for the outcomes, sensory and the motor assessment was done. A horizontal deviation of less than 10 prism diopter and a vertical deviation of less than 4 prism diopter and no diplopia in primary position was considered as the criteria for success. Of the 19 patients, 14 were male and the mean age was 39 years. Nearly 52% of the patients had vision about 6 by 18 to 6 by 36, 2 had less than 6 by 60 and 7 had a good vision of 6 by 6 to 6 by 12 despite buccal. Strabismus was most commonly seen in those patients in whom more than 2 segmental scleral buccal was used or who had underwent recurrent buckling surgery which was statistically significant. Horizontal type of strabismus was noted in 63%, but in about the rest 40% vertical and mixed type of strabismus was also noted. 2 patients were treated with prisms, 2 patients underwent botulinum toxin injection and 15 patients were managed surgically. There was no significant statistical outcome deviation between these 3 groups. Of the 2 patients who underwent prism, they had deviation less than 12 prism diopter with normal extraocular movements. Post deviation, they were orthophoric. Those who had deviation more than prism range and still the ocular movements were normal were given a trial of botulinum toxin in 2 patients. They had esotropia. An injection of botulinum toxin into medial rectus muscle made them orthophoric and an outcome of 2 PD successful outcome noted. In the surgical group, there were totally 15 patients. 4 had extraocular movement restriction. The buccal was removed only in 2 patients who had exposure and infection. 10 underwent conventional recession, 3 patients had hangback recession and 1 underwent each adjustable recession and muzzle transposition. 2 patients had severe conjunctival fibrosis and an amniotic membrane transplantation was done at the end. This is a patient who had hypertropia, underwent a conventional SR recession. The patient with exotropia who underwent adjustable lateral rectus recession, and this is the patient who had the buccal infection removed, following which there was IR was severely damaged and IO muzzle transposition was done as IR couldn't be retrieved. So through previous studies, we know that horizontal strabismus is most common after scleral buccal and mostly seen after repeat buckling surgery, and for treatment, previous studies advocate buccal removal. What new did we find in our study was, even though 64% of the patients had horizontal strabismus, nearly 37% had vertical and mixed strabismus too. It is the site of the buccal which is determinant for the development of strabismus. Management decision has to be done based on extraocular movement. If it is full with good fusion, prism or botulinum toxin can be tried, but a restricted or sensory type of strabismus surgery has to be tried. Only in complicated cases buccal removal has to be done, else by modifying our squint surgery with extensive careful dissection using antifibrotic agents like mitomycin and amniotic membrane or specialized technique like adjustable or hangback techniques, we can still retain buccal in most of these patients with strabismus. So with all these maneuvers, strabismus surgery in a post-buccal patients is a owner's envy but a neighbor's pride, that is we strabismologists' pride. These are my references. Thank you.
Why do you think that some cases develop strabismus after?
Sir, it depends.
Same site of scleral buccal, but some cases develop. It is not only the site but the tightness and direct
muscle damage, as well as when they are giving peribulbar anesthesia, that could also be one of the factor. And two, tightness of the buckle can actually cause a extensive fibrosis of the muscle, because they first put the encircling band and over that they put the buckle. So with those two things sitting at a place, if it's very tight, mostly the inferior rectus muscle immediately undergoes the fibrosis part. So that is one more. If there is fibrosis, we have to release that muscle rather than doing the contralateral plication. It doesn't work much.
Okay, thank you.
Thank you, thank you, sir.